Morning to all. At the outset, I have to thank the team Aravind for organizing such a wonderful CME. Yes, with a short span of time, the post-cyclonic academic feast. I personally congratulate Dr. Jaya Gayatri and Jaya for the Herculean task to arrange such a wonderful CME. So my talk is on ophthalmologist perspective of endonasal anatomy. I'm an ENT surgeon. So what is my role in dealing with dacryocystitis or patient with epiphora and watering aids? This is a basic. So we are all parent department. We are referring patient each other. And our OT, OR days also, OR room also we are there. So it's a teamwork. It's a teamwork. Most of the cases, and I have a little few experience in endo DCR in just past 5 years. I'm not a big surgeon dealing with the laser and all, of course. So previous speaker, Madam Usaki, Madam, is a wonderful talk. You saw that the role of laser in endo DCRs. So mostly fresh cases with a perfect nasal septum, no big endonasal block, anatomical block, and no big septic focus. So you can go ahead with straightforward DCR, endo DCRs. No role of big laser. So where the laser is applied for advanced fibrotic cases, where the anatomy is very difficult to locate the sac, where the fibrotic bands between the mucosa and bone, where you can use a laser. So here I'm going for first to go with anatomy. This has already been discussed. So my previous speaker, Professor Rajalakshmi Madam, made my job very easy. So I don't want to go much in detail about the anatomy of nasolacrimal apparatus, drainage pathways, and the bone and anatomy. So I want to share my little experience in the DCR for over the years. So this is a basic canaliculus, you know, the upper and lower canaliculus, nasolacrimal duct, and all that. So if you visualize the endonasally, you can see the inferior turbinate, inferior meatus, where you can see straight away the nasolacrimal duct opens. So most of the time in infected cases, you can see the pus point draining in the inferior meatus. So the diagnostic nasal endoscopy is first gold standard to go with before embark endo DCRs. So this is a cadaveric bone, how it presents. So this is a part of the bone very close to the medial canthus, and this is a part of the bone, everything. So your sac is here. It's almost very close to your medial canthus. So this is a duct. This picture, you can see straight the length of the nasolacrimal duct can assess by even the cadaveric dissection itself. It can be well correlated with CT scan. So where the duct is opens, the length of nasolacrimal duct. Why this measuring length is very important? We can go with duct stent. We are placing a stent and probing. We are stent and so probing. So how to probe? From the upper canaliculus to the nasolacrimal duct sacs. So you can assess. So we never give any big damage to the nasolacrimal duct, and it will prevent complications like stenosis and any fibrosis post-operatively. So the assessment of duct, and as well as the CT correlation and with endoscopic anatomy. So the radiology is very important. The radiological assessment of the turbinates and anatomical block in the level of lacrimal sac, like your gross septal deviation. Your gross septal deviation can completely compromise your endoscopic view due to the endolacrimal sac apparatus. And especially your turbinates and this area. This area is very important to go for access. So that's why the septum, to assess the septum in the midline, is very gold standard for any endoscopic surgeon to deal with endo DCR. As well as followed by nasal polyps and any other anatomical obstructions over the level of lacrimal sac, and it gives a very difficult to give exposure for the sac. So another part is the pneumatized agar-nasal. This agar-nasal is see how it is very close association with your lacrimal sac. So this is nothing but a pneumatized ethmoidal air cell. It gives a big blockage over the outflow tract, not only the sinus tract of ethmoid sinus, as well as the exposure to the lacrimal sac also. So the two events to prepare the patient before endo DCR, one to relieve from all septic focus sinuses, especially ethmoid sinus should be free. Your ethmoid air cells should be free. Your ethmoid sinus should be free of sinusitis and allergic rhinitis both. So allergic rhinitis and sinusitis, for the both things you have to treat previously before embark any procedures in endonasally, and as well as rhinitis. These are the basics. So that's why we are giving our opinion before endonasal surgery, any even external DCR, we are giving for any septic focus. We are referring the patient to ENT to rule out any septic focus in sinuses, ethmoid, maxillary, and rhinitis, rhinosinusitis, all these things. Of course, nasal polyps and anatomical problem in the septum. So these are the things we evaluate before embark any surgical procedures in endonasally to for the better outcome of the patient. So this completely awareness is, so in this situation, if you proceed with endoscopic, first you have to correct, this is not a big issue, your septum is well down. No, so my area is here. I have to expose the here. So this part, you have to remove this agarnase first. So with this agarnase, with this pneumatized agarnase, it's very difficult to go for a sac exposure. So you have to very carefully, that's why the CT have a big role to assess the orbit and agar cells and exposure, and then further entry into the lacrimal sac without damaging the orbit. As well as the left NLD obstruction already been discussed. So this is another CT finding where CT itself, you can go with nasal lacrimal duct block. So these patients you can select for endo DCR. This is ideal patient to go for endo DCR, such a block, and you remove. I think the rest of the structures is turbinate, everything you can assess. Sometimes you may sacrifice the middle turbinate also. Usually the inferior turbinate is inferior meatus is a drainage pathway. The surgical exposure is sometimes you may need to resect your middle turbinate in total. This is turbinate. You have to expose for the lacrimal zone. So this is up to the surgeon to decide whether you have a exposure. So our only aim is to go expose the uncinate process and middle meatus anatomy along with the lacrimal sac in. So now this picture one by one we can see how. This endoscopic exposure. This is, you see, this is middle term over empty. This is uncinate. Okay. It's a concentric bone. It's a C. It's a C. See, come. So your lacrimal, this is a lacrimal zone. This is a lacrimal zone. So the start with the incision. So though the laser shoot, you can shoot out this part. You can use with the bloodless field. So conventionally, you can inject, infiltrate, and you make a flap here. Okay. So this is axilla. This attachment of middle turbinate, we will call it as a axilla. Your sac is fundus is here. So fundus is here. So your incision must be like this from entire. So this exact uncinate process, this is only to expose your nasolacrimal duct. So your dissection start from down to up to reach the sac fundus. Okay. I will show you my video after that. So you can follow this endoanatomy and relate to my video next. So the incision is infiltration here. The incision is like this. Then you flap. You can see again, so here this is the part of the bone. This is not a sac, it's a nasolacrimal duct. This punch is in the exactly duct area. So you have to again open the lacrimal bone proper to expose the fundus. Then only you will reach this height, you can expose the sac one. Okay. This is a complete exposure of the lacrimal bone and sac. And finally, this is the uppermost exposure. Uppermost exposure, still you see the entire sac in the gate. So now this video, this is infiltration. This is a part. This is a middle turbinate. This is uncinate. This is our area of interest. Our area of interest. The surgeons can make incision either way. So when I was a postgraduate, that time there is no big tools. Then they make incision once close to the like this and expose with the medial flap, this mucosal flap, and they keep the flap preservation those days. Now, after the evaluation of endo DCR in past decade, they are not preserving the mucosa. And some surgeons in Bombay, they are exposing entire sac outside. They are removing all the mucosa out. They don't want to get any complication because of the free mucosal flaps in the operated site of lacrimal zone. Even some centers in UK, they make a flap, both they clip the medial wall of the flap, like a mucosal preservation concept in FES. But our aim is to remove the entire sac, expose the sac, marsupialize the sac out remove the entire mucosa in order to prevent further complications. That is our recent learning information from the most of the surgeons. So this is the zone. This either you can make this incision from level of turbinate here, or you can make like incision like this up to the landmark of uncinolacrimal groove. So uncinate process, lacrimal bone. So this is uncinate process. This is uncinolacrimal groove. You can see the groove now. So this is the uncinolacrimal groove. So this groove will separate uncinate process and lacrimal bone. Okay. The mucosa once crosses the uncinolacrimal groove, your sac is in exposed. You are in right plane. You are not in false plane. You are in right plane. This uncinolacrimal groove will give a limit. So this is a lacrimal area. This you can start with here dissection further. So this can I play video? Oh, yeah.
This is a case of left-sided endoscopic dacrocystal rhinostomy in a 70-year-old female patient. Intranasally, lignocaine 2% with adrenaline was given. She is having complaint of left-sided eye watery discharge associated with pus, and Roplast test was positive in the left eye.
And this is the port middle turbinate, and this is a knife, plain knife. You can make incision here, and this is the lowest port. When you have use the elevator, this elevator you can see the access and go with punch. So now we have a DCR punch.
Now with the help of Freer's elevator, middle turbinate is medialized to a better exposure of the lacrimal sac area. Then incision is kept just above the inferior turbinate horizontally with the 15 number knife.
So instead of this knife, you can use a laser. That's all. Instead of this knife, 15 blade knife, you can use a laser pointer. You can separate the mucosal flap over the uncinolacrimal.
Another incision was kept horizontally from the axilla of middle turbinate.
The axilla,
and both the incision were joined in the U shape.
Is very important area. Unless you expose the axilla, you never expose the lacrimal sac in total. So the axilla exposure is very important.
Now, inferiorly, the flap is elevated to expose the lacrimal bone.
So this is a flap. See, the flap is coming to here. This is uncinolacrimal groove. So simple Freer's elevator, we have only 3 instruments. The conventional endo DCR,
we can see the
any centers, you need only 4 instruments. Your elevator, your knife, one DCR, and Harrison punch. The punch is called Harrison's punch. It's available. It's a basic instrument in all ENT or operating room. So Harrison punch is a basic punch, but now they developed an endo DCR punch. So what is the advantage of endo DCR punch, Harrison punch? The endo DCR punch exactly anatomically designed
now
in
with
such a
the
way
help
that
of Harrison bone
go
punch,
and fix the lacrimal
we will
bone.
remove the anterior lacrimal crest to expose the lacrimal sac.
So this is a Harrison punch.
Bone is
NLD
removed
this is NLD.
Surrounding the lacrimal sac in 360-degree direction.
This is Harrison's punch. See the punch.
Now
this
we
punch
can
now
see
designed in such a way that
lacrimal sac, which is
the latest
exposed.
DCR punch, easy.
Surrounding
Any SR, anything
bone
you
is
can go
removed.
easily with the DCR. Not very difficult, easy for the beginners. So this is the original Harrison punch is very big. It's upset in the field. But DCR punch is very lightweight and very angulated in such a way that it go and straight away fix the nasolacrimal duct. You don't have any problem at all in exposing that duct as well as the sac. So now they expose duct. So from the duct, you have to trace above the sac proper. From the NLD, white point, then you have to reach the sac proper and go here to expose the sac. So this bloodless area you can avoid by using a adrenaline pack or you a Merosil pack. So we have a Merosil. Merosil means it's a sponge. It's a sponge filled with adrenaline and portmogylocane. You can keep there as a pack. You can give a bloodless feed. Okay. Then slowly you can see the expose the lacrimal sac and the sac exposure is little difficult. So here, what are the bones you remove for the postgraduates? So what are the bones removed in endo DCR? One is lacrimal bone proper. Another part bone is frontonasal process of maxilla. The part of frontonasal process of maxilla, it obstructs the fundus uppermost part. So the lacrimal bone removed in toto as a one chunk, and part of the frontonasal process removed the 2 bones. Once you remove the entire bone out, Your sac is in view. Okay, then after that on the sac, then go for a.
Then we will put.
So here, now the incision, then the madam makes for cruciate incisions. Incision either make along the flap, along the sac, you can make an incision. Once you put an incision, it becomes a medial flap, lateral flap. Okay, you got the point. One is the pus is, I think pus is came out. No, say the flap. Now they're entering into the sac and releasing the medial flap, lateral flap. So this flap, you have to remove it out totally. You got the point? So
Now
sac,
we will again do the
incision
probing
and the flap.
in the inferior punctum
Go back and
to confirm
where the important
whether needle is coming.
Yeah, after the pus exposure, pus is coming out. This is the medial flap. Okay, you are putting a incision to push it straight. The medial flap, lateral flap. This flap must go out, or the entire sac must be out. So generally, the flap will never go into the lacrimal bone again.
Now we will again do the probing in the inferior punctum to confirm whether needle is coming in the sac or not. Now we can see the needle is coming out from the sac, and sac is emptied with suctioning.
Okay. It's a final syringing available. Okay, final syringing. Here the punctum is there, and finally you can make a merocil, a simple merocil. You can make a nasal merocil.
After emptying the sac, superior and inferior flaps are marsupialized.
Yeah, see how the flap is blue. There is no flap. So previously they preserved the flap. Now they removed the for the complete. The flap is being cut. So now after the endoscopically post-operatively, straight away you can see the lacrimal part alone. You don't see anything, any mucosal area alone.
Now we will keep the apture over the flaps.
Need a good follow, proper syringing, and you can give a merocil pack. That's for post-operative. It's a daycare procedure. No big deal. Then actually after the week you can follow with the this is point merocil can keep even 5 days without any infection.
With the help of apture, flaps remain in the position.
Area. Not atraumatic area. After the procedure, you can keep the nasal pad with the merocil along with the.
In the last, we will pack the nose with merocil to prevent the post-operative bleeding from the nose.
So this exposure.
Thank you.
First, the aim. So the aim is the exposure of sac, and then nasolacrimal duct identification, and the incision made in the sac exactly, and make it into two flaps, medial base, lateral base, and medial basal flap is excised completely in order to keep the sac syringing part can visibly see. Then followed by a periodic follow-up and endoscopic examination and proper follow-up as well as the syringing pad. So here we need a ophthalmologist, surgeon's support for the proper punctal dilatation, very important step. So you can use a proper size of the needle punctum, because otherwise you may damage the lacrimal duct as well as the. Why I am saying this? Early days of my friend, they used stent, but stent has its own failures. Lacrimal stent, it was a big thing in decade. I think Daher would accept. I mean, correct. The lacrimal stent, it was very popular those days. And after the follow-up, most of the patients will come with the stenosis. The stenosis, the stent producing stenosis is a very big thing. You can't revert. You can't revert. It's very, very flimsy apparatus. Very flimsy, very narrow stent. That's why the proper assessment of the duct, punctum dilator, size, syringing, everything is very important. So my role is very simple. I can straight away expose the sac, make incision out. But the syringing pattern, syringing identification, proper follow-up is very, very important for the successful endo DCR. Again, once again, I thank Team Arvind for organizing such a wonderful CME in short of time and give me the opportunity. Thank you. Thank you very much. Thank you.